Welcome to VNA Health Highlights, a program of the Visiting Nurse Association of Cape Cod. I'm Jeanne Sarnosky, and on today's program we're going to learn a little bit more about the Navigator pilot program. We're lucky to have with us today Beth Albert from Barnstable County Human Services and Helen Malinowski, who is a social worker for the VNA. Both are part of this program and helping make it happen. So we're just going to learn a little bit more. Thanks for being here today. I appreciate it.
Thanks for having us.
Thank you.
So I always like to start for the viewers to get a better sense of who you are and how you've come to be where you are. So Beth, I'll start with you.
All right. Well, I'm the Director of Human Services for Barnstable County. I've been with the county for 5 years. I do come from a background working in the area of aging and disability, so the Navigator pilot project is something that we've been thinking about for a long time at the department, and really happy to be part of it in the VNA, working with the VNA on this.
And how did you get interested in just this field in general?
In the field, I actually have a master's in social work.
Okay.
So, you know, I went to school and became a social worker and have an MSW, but I was always more interested in policy and programs as opposed to being a therapeutic or counselor kind of person. So I've been on the Cape for 5 years. I lived in Philadelphia for 20 years.
Wow.
And worked in various health and human service organizations, but always was drawn to aging and disability. The position I'm in now provides opportunities for me to have my fingers in a lot of different areas.
Right. So are you officially now a Patriots and a Red Sox fan now that you've been here 5 years? Or? Okay, we won't.
Oh, I don't know if I'll respond to that.
That's all right. Safer not to.
Yeah, thank you.
And what about you, Helen?
Well, I also have an MSW. My concentration in school was gerontology. And
great.
It's hard for me to really pinpoint exactly how I got into that area, but it's allowed me to work in a variety of different capacities. I've worked in long-term care and skilled nursing facilities. I've worked in group home environments. I've worked in hospital settings, and most recently, about a little over a year ago, I started working with the VNA as a medical social worker, and very, very much enjoying it and very excited to be part of this project.
This is a great project, it sounds it, yeah. So let's help people understand it a little bit more. It's a Navigator pilot program. So what is that exactly?
Okay, well, I'll jump in there to give you kind of the history and the background. So in my position as the Director of Human Services, I get to interface with a lot of different groups, and our mission primarily is to connect and work on collaborations and help groups communicate better. And so for the past several years, I have heard from various people that there seems to be, people have difficulty figuring out not only where to go for what, but even if they get some information or a referral, if they have complex issues, you know, they're working on housing and financial and you know, insurance and equipment, for example, they may know where to go, but they needed some additional help, as I call kind of being pulled through the system. And so I had heard it from enough people that really felt it was something that was not in existence on the Cape and Islands, on the Cape, I should say, and so worked with using some other models that are out there, case management models, but really pulling together a case management and advocacy model to give people a little bit more help than they may get with just straight information and referral or case management. So it's short-term intensive. Our goal is to work with anybody the age of 18 or over. So this is people with disabilities and seniors. We don't have any income qualifications.
Okay.
And we're piloting it because we need to find out if, kind of as I say, to test the hypothesis that there are these group of people on the Cape that need additional case management and intensive advocacy to get to the next point. And so that's kind of the concept. It's we're being very, very careful not to duplicate anything that's already existing. We feel very strongly this is not meant to duplicate anything that's already out there. So I know Helen's going to give you some case you know, examples of some of the folks that she's working with, but So it's a little bit different, it's intensive, there's a big advocacy component, and we can really meet people where they're at physically as well as emotionally or with their health condition, and kind of get them to the next level. So that's the concept. We're testing it. It's an 18-month pilot. We're in about month, I don't know, 5 or 6.
So it's not just health. I'm going to just interject some clarifying questions.
Sure.
It's not just health issues, or is it?
No.
No. As a matter of fact, there seems to be a lot of support for people with simply health conditions or chronic health conditions.
So that kind of help is already covered out there.
To a certain, yes, it is. Yeah, I think it really is, and I think that we're finding that. We're seeing a lot of people who are struggling with what you might call like comorbid conditions or dual diagnosis, people who are struggling with mental health problems, with addiction issues, and superimposed on top of health conditions. It makes accessing the system much more difficult.
So it's on top of health conditions like diabetes, or chronic health conditions?
Chronic health conditions or disabilities. Think of some of the examples of the people we're working with right now. Let's see. As a matter of fact, most of the people we're working with right now have primarily, I would say, mental health or substance abuse problems, but people who are legally blind.
Okay.
Maybe a category that we're dealing with. People, yes, with out of control or uncontrolled diabetes. We're dealing with a lot of people who have anxiety issues, depression issues, things like agoraphobia and panic disorder, which really simply seem to overwhelm that person in terms of accessing what they need.
So where is the case management, Beth, for example, in your discussion? It sounded like this is additional case management, maybe, of things that are falling through the crack. Where are they getting, who's doing the case managing now for some of these?
Well, I think people are coming. We're getting referrals from a lot of different sources. So we can get referrals from agencies who are dealing with someone who has some very complex and multiple issues and need this short-term intensive case management and advocacy. And then the goal would be then to, once the person got situated and got into the systems that they needed to get into, then they would be referred back if they did in fact have this long-term case management. I think for most people, and you've probably had some referrals along these lines, so I'm gonna let you talk about that, but that was how we envisioned it. I think if anyone's, the fact of the matter is there are not too many systems that have case management. It's not a reimbursable service in many instances. Funds for case management have been cut in the past, and so when people hear case management, it really means different things to different people. So I think there's very few services that have kind of that long-term, what you would consider traditional case management, where someone's assigned to you and they're going to stay with you for a long period of time. How I look at this is, the system to me is there are those folks that have the long-term case management. It's few and far between. Lots of people get information and referral and get a little bit of help. But this is kind of, again, we're testing this hypothesis that there's a set of people who need this additional help to kind of be successful and to be independent.
So when they get a little referral or a little bit of help, where is that coming from now? Is that like from the hospitals or from?
Elder Services has a really fantastic information and referral program. At the hospital, there are the discharging nurses at the hospital can provide some information and referral.
Some people that now might call the senior center if they're out there on their own.
Councils on
Aging. And they don't know where to get help. Would they be at the Council on Aging and then call them and say, hey, where do I get help with
the
blah, blah?
The Council on Aging and Elder Services, and this is one of the things that I think we are finding. If you're over the age of 60, you can go to the Council on Aging, you can go to Elder Services, and you have this pot of resources. For people who are under the age of 60, but have disabilities or are having some chronic health conditions, they can't turn to those same resources. So the aging resources are pretty strong in the area.
Just by nature of
just by nature
the
of
population, that we're set up to accommodate a lot of that population, but maybe not. So is that what you're seeing, the 18 to?
Well, that's, I mean, we're,
most of our clients are in, I would say, in their 40s and 50s.
so again, this is
Oh,
new.
yeah.
This is brand new, so we don't have a lot of
Sure.
data to show you right now or to talk about right now. We launched we contracted with the VNA in the spring. There was a 3-month startup period, and so really you just started taking calls in what, August, the beginning
August
of August.
1st.
Oh, good.
So we have a month and a half under our belts. We're looking now. We're going to be collecting. The VNA has been collecting data on who they're serving, so we're going to have a sense of who we've served
Great.
in the program in the aggregate, and could come back at a later time and tell you about that. But right now, I
Sure,
mean, we're
yeah.
just it's brand new. So
fresh, yeah.
we didn't really know. We thought we knew where we were going to be getting some referrals from. So it would be interesting to see who we're actually getting the referrals
So
from.
logistically, it's Barnstable County working with the VNA. So how did that?
So logistically,
Behind the
we
scenes,
put
how does
out
that
we
work?
put out an RFP. I had over, a year and a half had cobbled together a pot of money in planning for this, because it's not something that was existing funds for, and we again wanted to pilot it, collect data, and really evaluate if it was necessary and how it was working. And so the county Department of Human Services put in some money. We got some seed money from Cape Cod Healthcare, and we got a grant from our Chinook 27. So with those funds, we were able to put out a $90,000 RFP. VNA was the successful applicant, and so the county is now involved with the advisory group and with the data collection and with the program evaluation piece, and working pretty closely with you guys as things come up. Not that I'm an expert in the area, but I think it's really important that we track what we're doing, and because we're trying, do we need this or not? Is it
Right.
something that we should continue long term?
Right.
I think that's something that we are teasing out as we get new referrals in, as we get phone calls in. We try to reach everybody back. We try to return all the phone calls as quickly as we can, and get as much information over the phone as possible to figure out who is this person already working with, what agencies are already involved, is there other case management, and what are their needs. And looking at the bigger picture, is it a matter of simply giving them some more advice, or maybe some more information about different areas to try, or have they really exhausted their ability to access the programs and the services that are out there? And then those are the clients that we are taking on under our program.
Yeah,
right
so
now.
that's an important point. There is a screening process so that you're not taking people who should be being served elsewhere, or who
That can
are,
be served
or
elsewhere,
can be served
right.
elsewhere. Exactly. And we also have an advisory group that we've put together. The VNA has put together that has some key provider agencies at the table, and so that group is being used to advise and do some case review, so that we're making sure that people are going to where they should be going.
How large of a group is the advisory board?
Oh, it's less than 10. I'd say about,
Oh, yeah.
about 10.
And so you have representatives from,
We have representatives from CORD, from the community,
which is, just for the viewers to,
Cape Organization
For the Rights of the Disabled.
Okay.
Elder Services.
Elder
Services,
Services,
people should
the
know that
Community
one.
Support,
I don't know
Deb Saucier,
the brain injury.
the brain injury
Okay.
group.
Injury program.
We have a representative a nurse out of Cape Cod Hospital emergency rooms. They have
Oh.
a new up-and-coming case
Ambulatory.
management ambulatory care program.
A Council on Aging outreach worker from Dennis, and somebody from Beata Nurses.
yeah.
Yes, Beata Nurses
Um,
Home Care.
The VNA, somebody from the MS Society.
okay.
And
Ronnie.
a representative from SHINE, which is an organization and volunteer organization serving the health information needs of everybody.
Okay.
Okay.
That's a
I
good
think
group.
it's a
So
good
that
group.
captures probably a good percentage of the people who might be running into these people in need? Is that?
I would say that's accurate.
And they represent different segments of the service provider, so that if you're getting a referral from someone who could be better served by a Council on Aging outreach worker, the person at the table representing that sector then can say, well, wait a minute, this is something that they could be getting from the Council on Aging. So it's to help the two navigators
Right.
as well. Helen's one of two.
Right.
There's two of us.
Good thing.
Yeah, thank goodness,
Yeah.
right?
Is it? Yeah, that kind of busy already.
We've been getting a lot of telephone calls. We have
yeah.
been getting a lot of calls. I think we
So
are.
who do the calls come in from?
Actually, it's interesting. A lot of the calls are actually coming from the clients directly. Someone is passing on our information. People have been getting information from the Cape Cod behavioral health groups. Therapists seem to have our information. The Council on Churches has been making referrals.
So there's a lot of flyers out there
There-
that went to everybody. So
Absolutely.
sometimes you're getting calls from me, the end user, saying, hey, I saw this flyer, can you help me with blah, blah, blah? At which point you would say, well,
Let's
take
talk a
under
little
this
bit.
case under advisement and we'll
Yeah.
see. And then it may come back with
Why
Council
don't
on
you-
Aging already had, you can get this from them and you can get something else from somebody else.
Absolutely.
Okay.
We do that. We also, so if we're getting a phone call from someone, and this is really their first attempt to get some help,
And this is the actual
person
end
that's,
user
user,
themselves.
the
Okay.
consumer that's calling us,
Okay.
we do make suggestions and see if they're able to follow up.
Okay.
Before we take them on as a client. And then there are some calls that we get that are just clearly so complicated that it makes perfect sense for us to become involved.
Okay. Now, does each one of these cases go to the advisory board for, what do you think? Or you're making executive decisions
We're
as you go
making-
based on the criteria that you've been given to?
We're making executive decisions based on the criteria.
Okay.
We're given the freedom, I suppose, to use our judgment
Right.
and decide who fits and who doesn't fit. And then we do come back to the advisory board after a period of time and say, this is who we're working with right now. And what are your thoughts about this group of people as consumers?
The key to this too, and I think the one of the reasons why the VNA was a successful applicant is they had two highly trained social workers who have a lot of background in gerontology and are looking at this not from a medical model perspective, but more from a social service model. And I think that is making a difference.
It really is. Being able to have the flexibility to use our clinical judgment, to go out in the community, see people wherever they need to be seen, whether it's in their homes, meeting with them at court to help them navigate a legal issue, meeting with them at the Department of Transitional Assistance or Social Security or legal aid. It really gives us the flexibility to meet our clients where they are at, to do whatever it is that we need to do to help pull them through the system, as Beth says. It's quite exciting, actually,
Yes,
to be able
I
to
bet.
do this.
I bet. So have you had some real interesting cases
We have actually had some very
that you feel
interesting-
really good that this is a big success and it's going to make a difference in this person's life?
We really have. One of the first telephone calls that we got, actually, I think, has been someone that has been very receptive to the help, very eager for assistance. A woman who's in her mid-50s who has been struggling with panic disorder and agoraphobia, has really been fighting to get access to
Agoraphobia
agoraphobia.
is?
Agoraphobia is a person who struggles to get out of their home because
Okay.
they have a fear of being around other people.
Okay.
So she, on top of this, has health issues, has been surviving off of some monies that she had for quite a number of years. And when that was running low, realized she wasn't able to go back to work and was really at a point where she didn't know where to turn. Applied for disability, was denied, and ran out of money, and had been living in her apartment for about 10 years. Her friends helped her piece together some financial assistance so that she could stay there, but she was taken to court by her landlord And at that point, someone came across our number and she called us. Well, in fact, her friend called and said, please call my friend back. Since then, we have worked not only on doing the reconsideration for disability, which is a lot of paperwork. It was very overwhelming for her. We have gotten her set up with some small amount of assistance through the DTA, got her connected to legal aid in the event that she has to go back to housing court again. We have pieced together some financial assistance to help her stay in her apartment while we're waiting on the report back from disability. And through some just pretty basic supportive counseling, she felt confident to go to a familiar person and get a part-time job. So it's working in a lot of different areas.
Right.
We have the beginnings of a long-term plan in
Right.
place.
Were you so excited? Were you like,
Yes.
yay, this is
Yes,
such a-
it was very exciting. It was
Yeah.
very exciting. But I did, because she has a hard time leaving her home. I met her at the various different appointments we had to go to, and helped walk her through some of these systems.
Wow. So is she then likely to stay with the program, or how long does this relationship last?
We're looking at about a 4-month time frame.
For anyone? I mean, that's just
It's
sort of
sort of an
ballpark.
average.
It's a ballpark.
You're not
It's
gonna
a
know
ballpark.
until you have
You're
them.
going into this, and we know we know it can't be long term, but it's got to be significant enough to be there. So what we thought was a 4-month period of time, and then there would be, hand the person off, or they would hopefully get to where they need to be, and then check in with them a certain number of times afterwards. But we're thinking that we're going to reach about 85 people in a 12-month period. So that's the plan. Again, it's a pilot.
Yes,
and
yeah.
because we didn't know what we would be seeing. So
Right. So if you're not hearing from someone directly, the client, are you hearing from, though it sounds like you are, but are there other people recognizing a need, like this person had a friend that called? So do you have agencies call, or?
We've had doctor's office, primary
Okay.
care doctor's offices calls. We've had telephone calls from Elder Services, from the Council on Aging, some of the senior centers, outreach workers have called us. We've had telephone calls from, oh my goodness, from even in the substance abuse field, from some counselors working at some different recovery
Oh, yeah.
type clinics.
Yeah.
It's
Wow.
it's really across the board.
Right.
It's really across the board.
So the word is out.
Most certainly the word is out.
We have to be careful what we wish for.
yeah.
Or is that the ideal? Is it something that this takes off like a wildfire, and there is recognized a true need?
Balancing that is we don't want to overwhelm these two women,
Right.
and if you're doing this intensive short term, I mean, there's just so many people you can be working with
Sure.
intensively. So we've already started.
We have a short wait list.
Oh, wow.
Unfortunately,
Yeah.
I hate that we have to say that, but
Yeah.
we do have a wait list at this point. It's not very long. We are still obviously taking phone calls and taking referrals.
Right.
And
But some might be, once you screen them, they can go through other systems.
And that's what we're trying to do when like
When you
I
get the
said, when
call.
we get the calls,
Yeah.
we make suggestions. If we're not able to help right at this moment, we make suggestions. Try X, Y, and Z, and your name's on the list, and we'll call you back
Oh, yeah.
when we are ready to take you on as a client.
And there's no fee involved?
No fee. No fee, no eligibility, income eligibility. Because what I had heard, from various people, were many times the people who are really having the most difficult time don't qualify because their income's just a little bit too high for some existing program. So we didn't want to make that a barrier.
Part of it, right.
So no income. It's basically a resident of Cape Cod, Barnstable County. Having the disability, having the complex needs, and your needs can't be met with an agency or an organization you're working with. What's the other criteria?
18 and
18 and over.
18 years of age
Right.
and older. One thing that is important to note is we don't have financial resources
Yes.
ourselves to
It's really important.
give out to clients. We have gotten some of those telephone calls. And we can't provide transportation. We can help get people set up with transportation.
up with
we
someone,
can
right.
meet them wherever they need to go, but we can't drive people around in our cars. So.
Oh, wow. It's a great program.
Very exciting.
Yeah.
It's exciting, and it's nice to see it, and again, being very mindful that we don't want to duplicate. This is not meant to replace all of the wonderful services that are out there, but it's really to kind of figure out, is there a need for something, and what are the barriers and issues and gaps that people are experiencing. So this will inform us and lead to some next steps.
Yes.
So we have some evaluation at a 6-month interval and 9-month interval, and then at the end too. So
Great.
Yeah.
We only have about 1 minute left, if you can
Okay.
believe it.
Okay.
Is there anything that we haven't talked about that you want,
you want the
viewers to
number?
know?
The phone
Maybe.
number.
Sure. Oh, no. So look it up. We should know this.
I know I should know this, but I unfortunately don't call it myself very often. The best number to make a referral at is 508-957-7629.
Very good.
All right.
Writing that down. All right.
right.
Thank you so much
Thank
for
you.
being here. I appreciate your time and all the information. It's a good program. I wish you success.
Thank you.
All
Thank
right.
you for having us here
All
today.
right. And I'm Jeanne Sarnosky, wishing you good health and good health care.